Hello everyone, hope you're all safe and well. In this lecture, we're gonna continue the methods of gaining space. Previously, we explained that the methods of gaining space are either non-extraction methods or extraction methods. As you know by now, that there are several non-extraction methods. We discussed the proximal stripping as the first method for gaining space, its indications, contraindications, and the instruments used for it. The second method was the expansion of the maxillary arch, either by slow expansion or rapid expansion, the appliances used for each, and the difference between the two expansions. In the current lecture, we'll discuss the other non-extraction methods and the therapeutic extraction method. The remaining non-extraction methods. The third non-extraction method is the distalization of the molars. What does distalization mean? It means we move the last molars backward and distally to create a space in the arch on the mesial side so that we can use it to relieve crowding or for retraction of a proclined teeth. It is preferred to do distalization of the first molar before the eruption of the second molar, as it's easier to be moved with less resistance. The appliances used for distalizing of the molars are of two types: the extraoral distalizing appliances and the intraoral distalizing appliances. The most commonly used extraoral appliances for molar distalization are the headgears. You took in the orthodontic appliances that the headgear consists of three parts. The first part is the face bow, which is a preformed metal framework composed of an outer bow that comes in different lengths and an inner bow that comes in different sizes. It connects to the maxillary first molar as we insert it in an auxiliary tube on the molar band. Therefore, the force is applied to the first molar via the face bow. We select the face bow and modify it to fit the patient's maxillary arch form. We adjust the inner bow to fit closely to the arch with omega loops or stops that are placed mesial to the tubes on the molars, so that the anterior portion of the bow is about 4 to 5 millimeters away from the maxillary incisors. The anterior portion of the face bow should fit comfortably between the upper and the lower lips. The second part is the head cap, which is a strap or a number of straps that runs around the back of the patient's head or neck, from which the appliance gains anchorage. The third part is the attachment, which is considered the active component that joins the outer bow to the head cap, which might be in the form of rubber bands, elastics, or coil springs. There are different types of headgears. We have the cervical type, where the anchorage is from the back of the neck, and we have the high pull type, where the anchorage is from the back of the head, or a combination of both types. We select the type of headgear to be used according to the case. Headgears can distalize bilaterally, where both the right and the left molars are distalized. Also, it can distalize unilaterally, where the molar on one side only is distalized, meaning either the right or the left molar moves distally. For bilateral distalization, the omega loop or the stops placed in the inner bow are on the same level to distalize both the right and the left molars. While for unilateral distalization, the omega loops or the stops is placed more distally on the side that needs distalization in comparison to the other side that will not be distalized. What do you think happened when we distalize the molars? The mandible will rotate downward and backward, leading to opening of the bite. In other words, the overbite decreases anteriorly. Also, the lower anterior facial height will increase. That's why distalizing of the molar is not indicated in cases with anterior open bite or in cases with increased anterior facial height. For the best results during treatment, the patient should wear the headgear for 14 to 16 hours per day. After reaching the results we want, the patient should wear the headgear for 10 to 12 hours per day to stabilize the results. The ideal force to be used is about 350 to 450 grams per side. The intraoral appliances used to distalize the molars mainly generate forces by including either screws, open coil springs, or wire springs with helixes. When the screws are activated by opening, they generate forces that distalize the molars. The open coil springs are activated by compressing the coils. As the coils tend to regain their shape back, they generate forces that distalize the molars. While the wire springs with the helixes are activated by opening of the helixes to generate forces that distalize the molars. There are different types of intraoral appliances used for the distalization of the molars. We'll discuss some of these appliances. The sagittal appliance is an intraoral removable appliance with split acrylic plate incorporating screws. These screws are the active component of the appliance. The position of the screw and the way the acrylic is split will indicate in which direction the teeth will move. For example, if the screw is placed perpendicular to the premolars and the molars, and the acrylic is split in two halves, when the screw is activated, the molars and the premolars will move in a buccal direction as in the bilateral expansion. But if the screw is placed parallel to the molars and the premolars, and the acrylic is split in a way that the molar that needs to be distalized is separated from the rest of the arch, when the screw is activated, the molar will move in a distal direction. So, distalization of the molars can be achieved by the sagittal appliance. The appliance on the left, as you can see, has two screws placed parallel to the molars. The acrylic is split in a way separating the premolars and the first molars on both sides from the rest of the arch. When the screws are activated by opening, the first molars and premolars will be distalized. So, this type of sagittal appliance can be used for distalizing the posterior teeth. While the appliance on the right has three screws, two screws are placed as the appliance on the left for the distalization of the first molars and premolars, and one screw is placed perpendicular to the molars and premolars, and the acrylic is split in two halves for the expansion of the arch bilaterally. So this type of sagittal appliance can be used for bilateral expansion together with distalizing of the posterior teeth. The pendulum appliance is an intraoral fixed distalization appliance. It consists of a modified lens acrylic button that rests on the hard pallet for anchorage with stainless steel wire extensions bonded to the premolars with composite. The active component of this appliance is the wire springs with helixes. The mesial ends of the helixes are embedded in the acrylic button, while the distal ends are inserted in lingual sleeves. These sleeves are like tubes on the palatal aspect of the first molar bands. The activation takes place by opening of the helixes, then inserting the distal ends of the helixes in the sleeves, therefore generating forces that distalize the molars. On the left, the pendulum appliance was activated by opening the helixes, as we said, and the distal ends were placed in the sleeves and secured by blue elastic bands to prevent their dislodgement. On the right, after the distalization of the first molars and the removal of the pendulum appliance, an ends appliance which was soldered to the palatal aspect of the molar bands was placed to retain the first molars in their new position. You can see the spaces that appeared between the premolars when the first molars were moved distally. The distal jet appliance is an intraoral distalization appliance that is usually associated with ends appliance soldered to the first or the second premolar bands. Each side consists of a tube, a 90-node open coil spring, an activation collar with a lock, and a stainless steel wire extending through the tube, which is of 0.036-inch internal diameter. The coil spring and the activation collar are placed over the tube beside each other. The stainless steel wire that is embedded in the acrylic button at its mesial end extends through the tube and ends in a band called the bayonet band that is inserted in the lingual sleeve on the palatal aspect of the first molar band. The distal jet on each side is activated by loosening the collar locks with a special key that comes with the kit. Then slide the collar in a distal direction to compress the 90-node coil spring. Then tighten the collar locks back again. As the coil is compressed, it generates a force that distalizes the first molar. The Jasper jumper appliance is another intraoral fixed appliance. It is also used in the correction of skeletal class 2 malocclusions. The appliance is known to deliver light continuous forces. It is composed of an open coil spring that is activated by compression. The coil is covered with rubber sleeves for the protection of the soft tissues. It is placed in the buccal aspect between the upper and the lower arches, with its distal end placed distal to the tube of the upper first molar, fixed with a ball head pin passing through the tube from the distal side, while its mesial end is placed distal to the lower canine that is used for anchorage to distalize the upper molar. The upper right image shows the open coil spring of the Jasper jumper appliance was activated by compression that generates the needed force to distalize the upper molar. The upper left image shows the open coil spring with a rubber cover to protect the soft tissues from injuries. The Jasper jumper can be used to distalize a single tooth or distalize the entire arch. To distalize the entire arch, we bend the arch wire distal to the tubes on the first molars. So, the forces are directed to the whole arch through the arch wire. As the molars distalize, they will take the rest of the arch with them. For distalizing the first molar alone, the arch wire is not bent distally to allow only the first molars to freely slide distally. The Jones-Jagg appliance is an intraoral fixed distalization appliance. This jig is a ready-made open coil spring assembly that is placed on the buccal aspect of the first molar and the second premolar. It is used with Nance appliance soldered on the palatal aspect of the second premolar bands for anchorage to prevent the mesial movement of the premolars as the first molars move distally when the coil spring is activated by compression. In the upper images, you can see the Jones-Jagg appliance placed on the buccal aspect of the first molars and premolars. The distal part of the jag is ligated to the hooks on the first molar bands to prevent its rolling. On the mesial side of the jag, there is a stop with an eyelet tube placed anterior to the open coil spring. To compress the coil spring for activation, we tie the eyelet tubes to the bracket of the second premolars with a ligation wire. As we tighten the ligation, the coil spring becomes more compressed, generating a distal force on the first molars. The lower image shows the appearance of spaces distal to the second premolars as the first molars move distally. The lip bumper appliance is basically a wire that is partially coated in plastic at the anterior part, with the U-shaped loops on the sides that are needed for activation. The free distal ends of the appliance slide in the tubes of the lower first molar bands buccally. The appliance lines the front side of the lower teeth, removing the pressure from the lower lip and the cheeks. The perioral muscles pressure generate forces that are transmitted to the lower molars through the appliance. The lip bumper appliance can be used for minor molar distalization, for uprightening of mesially tipped lower molars, for regaining space for unerupted teeth as the lower second premolars, and when it's inactive, it can be used as a retention appliance. The lip bumper appliance is activated by opening of the U-shaped loops on each side, inserting the free ends in the molar tubes and securing it with elastic bands to prevent displacement of the appliance. The fourth non-extraction method is proclination of the anterior teeth, which is indicated only in cases where the anterior teeth are retroclined, and if the soft tissue profile will be acceptable with a stable outcome. Class 2 Division 2 cases are characterized by retroclination of the upper anteriors. The proclination of the upper anteriors creates space that enables the alignment of the upper arch with no harmful impact on the facial profile. The fifth non-extraction method is the derotation of the posterior teeth, which will create space in the arch since the mesiodistal dimension of a posterior tooth is less than its buccolingual dimension. The derotation of posterior teeth is carried out with fixed orthodontic appliance using a couple, which is formed of two forces, one force on the buccal side and the other force on the lingual side. These two forces are equal in magnitude but opposite in direction. The last non-extraction method is the uprightening of a mesially tipped molars, which creates around 1 to 1.5 mm space in the arch when the molar is uprightened. Here, the uprightening of the molars is carried out with fixed orthodontic appliance together with uprightening springs. Also, we can upright the molars by using mini plates or mini screws placed in the retromolar area together with the fixed appliance as shown in the images. Therapeutic extraction is the second category in gaining space. What's extraction? Simply, it's the painless removal of a tooth from its socket, of course, after giving the patient local anesthesia. Based on the diagnosis of the case and listing of the problems, we reach a treatment plan which might indicate the extraction of 1, 2, 3, or 4 units. The extraction here is for orthodontic purpose to establish a normal as well as a functional occlusion. As a step in the diagnosis, we do cast analysis in which we measure the perimeter of the arch, which is the space available, and we measure the mesiodistal width of the teeth, which is the space required. When we subtract the space required from the space available, we can know the amount of crowding in each arch. There are 3 degrees of crowding: mild, moderate, and severe crowding. When the space required is less than 4 mm, this is known as mild crowding. In such case, extraction is not indicated and we can treat the case either by proximal stripping or arch expansion. When the space required is from 5 to 10 mm, this is known as moderate crowding. According to the case, it can be treated either by extraction or arch expansion or molar distalization. When the space required is more than 10 mm, this is known as severe crowding. In these cases, extraction is surely indicated. For example, we extract the first premolars, we align and level all the teeth, then retract the canines in place of the first premolars, then retract the 4 incisors backward. Here you can see clearly the difference between the 3 degrees of crowding, the mild, the moderate, and the severe crowding in the lower arches when brought together. Why we do extraction and orthodontic treatment? There are many factors, but we will say only some that may concern you. As we said, in cases with severe crowding and some cases with moderate crowding, we extract to provide space for the correction of the crowding. We can extract in cases where the patient is not satisfied by his facial appearance, as he might have a deep bite or an open bite, or a protrusion in the upper with an increased overjet, or a protrusion in the upper and lower anteriors, which is known as a bimaxillary protrusion, or the patient might have an anteroposterior dental problem as angle class 2 and angle class 3 malocclusions. Also in adult patients with skeletal class 2 or class 3 problems, we can do a sort of a camouflage treatment without orthognathic surgery, which may require some extractions. For the correction of the dental anteroposterior relationship, as in class 1, 2, and 3 angle classification, we'll discuss the treatment of the basic cases. As you know, we might modify the treatment plan according to each case. When we have a patient with a class 1 molar relation and have malocclusion in the anterior segment as presented in the angle class 1 classification, for example in the form of crowding or a deep bite or an open bite or an increased overjet, in these cases we usually prefer to extract the 4-4 to have a normal occlusion and development between both arches at the end of treatment. In Class 2 angle classification, we have two subdivisions, Class 2 Division 1 and Class 2 Division 2, where the molars are in Class 2 relation in both divisions. In Division 1, there is an increase in the overjet. There might be some crowding or a deep bite or an open bite. In these cases, we most probably extract in the upper arch only. But there is no rule for that, as sometimes we need to extract in the lower arch too when there is crowding in the lower arch. While in Division 2, usually we don't extract. But again, it's not a rule. The most common treatment is non-extraction, as the severity of Division 2 is less than Division 1. In Class 3 angle classification, we're gonna reverse what we said in Class 2 Division 1. Here we have Class 3 molar relation. Usually we extract in the lower arch only, but it's not a rule, as we might have a patient with severe crowding in the upper arch. In this case, we will extract in the upper and in the lower arches. When we decide to extract according to the treatment plan, to select which teeth to be extracted, we should consider condition of the teeth, position of the teeth, and the position of the crowding. It is advised to extract severely carious teeth, teeth with large restorations or fractures, endodontically treated teeth, and hypoplastic teeth, than to extract sound teeth, even if it's going to extend the treatment plan or makes it more difficult. For example, we usually extract the first premolar, but if the second premolar is badly destructed, we rather extract it than a sound first premolar. Severely malposed teeth, which are difficult to align, are usually extracted, especially those where their apices need much movement, as torquing the apex of the tooth is more difficult than moving its crown. It is preferred to extract near the segment which has crowding. For example, when we have crowding in the anterior or the buccal segments, the most commonly extracted tooth is the first premolar, as it lies in the center near to the anterior segment and near to the buccal segment. Therapeutic extraction is carried out for the purpose of orthodontic treatment after we diagnose the case. There are different extraction procedures that are considered types of therapeutic extraction when used for orthodontic treatment. These extraction procedures include balancing extraction, compensating extraction, enforced extraction, serial extraction, and Driftodontics. Balancing extraction is when a tooth is extracted from one side of the arch. We extract the tooth on the other side of the same arch to maintain the arch symmetry. For example, a patient with deciduous dentition, when the lower left C is extracted, we extract the lower right C to avoid shifting of the midline. The compensating extraction is the extraction that's carried out in both arches, as we explained before, in Class 1 malocclusions with crowding in the upper and lower arch. We usually extract the fours in both arches to maintain the lateral arch symmetry and to have a normal buccal occlusion with no disharmony in the occlusion whatsoever. Enforced extraction is carried out in cases where the patient already has a badly decayed tooth with an abscess, or a tooth with massive fracture, or a periodontally involved tooth with bone loss, or an impacted tooth in unfavorable position that cannot be pulled out. In these conditions, we are forced to extract such teeth instead of extracting sound teeth. You took serial extraction as a method of interceptive orthodontics, where we extract deciduous and permanent teeth early after their eruption to treat the severe crowding. Usually, we extract the C's first, followed by the D's, then the 4's. Driftodontics is the concept of the natural migration or drifting of the teeth in the extraction space without the use of a fixed orthodontic appliance. For example, a case with lower anterior crowding. When the lower first premolars were extracted, the lower canines drift distally into the extraction space, causing sudden relief of the crowding in the lower anterior region. Unfortunately, this concept occurs to a less extent in the upper arch. The drifting of the teeth into the extraction spaces takes place mainly in the first 6 months after extraction. So the concept of driftodontics can allow delayed placement of the brackets in the lower arch, as we can use the advantage of driftodontics in our favor, meaning the orthodontist in some cases can refer the patient for the extraction of the 4 premolars, according to the treatment plan. Then bonds the brackets in the upper arch and postpone the brackets in the lower arch for around 3 to 6 months to allow for the relief of the lower anterior crowding as the lower canines drift distally into the extraction spaces. Then the brackets in the lower arch can be placed to continue the treatment and close any remaining spaces. After diagnosis and reaching a treatment plan, which involves extraction, you should know, according to each case, which teeth are going to be extracted and what will happen when we extract these teeth. We'll begin with the incisors. Usually we do not prefer extracting the incisors only if the tooth is badly damaged and cannot be repaired. It might be severely distracted, fractured or carious, or even has a dilacerated roots, or periodontally compromised. Also, in cases where the tooth is completely out of the arch and the rest of the teeth are well aligned and arranged in the arch with no spaces. For aesthetic reasons, the upper central incisors are never extracted for orthodontic treatment. The only condition is if it's severely fractured beyond the cervical margin and there is no hope of repairing it, or it has a severely dilacerated root and cannot be moved. In such cases, we position the lateral incisor in place of the central incisor using a fixed orthodontic appliance, and after finishing the case, we refer it to be crowned to resemble the lost central incisor. The upper lateral incisor is extracted only if it is severely malformed and cannot be crowned. Also, if it's severely malpositioned, being totally out of the arch, and the upper canine is small in size and it moved mesially occupying the place of the upper lateral incisor. In this case, we extract the upper lateral incisor and reshape the canine by rounding its cusp tip to look like the upper lateral incisor. We should avoid the extraction of the lower incisor as much as we can, as it causes the collapsing of the lower arch as it gets smaller and constricted anteriorly, resulting in an increase in the overjet, together with the lack of the anterior stop, leads to the over-eruption of the lower anterior teeth and the exaggeration of the curve of spee, while the intercanine wedge decreases. The lower incisor can be extracted only if the tooth is completely out of the arch or if it's periodontally compromised with gum recession and loss of its supporting bone. If a case with minimal crowding, where the crowding is less than 4 mm and the lower incisors are triangle in shape, we treat this case by proximal stripping to relieve the crowding and to make the incisors aesthetically more pleasing. It's contraindicated to extract the canines as they are the keystone of the arch and they give support to the lips that affect the patient's appearance. Unfortunately, sometimes we are forced to extract the canines when they are severely malpositioned or severely impacted in an unfavorable position that cannot be aligned or pulled out into the arch. These are the only conditions where the canine is extracted, as we always consider its extraction to be unfavorable. The position of the root apex of the canine plays an important role in the decision of whether to extract the canine or not. By radiographic examination, we can locate the position and the amount of displacement of the root apex as well as the crown. As you can see in the panoramic X-ray, the lower right canine is in unfavorable position and it cannot be pulled out, as it is nearly horizontally impacted, while the two upper canines are in a favorable position and they can be pulled down into the arch as they are vertically impacted. The premolars are the teeth that we commonly sacrifice for orthodontic treatment. Crowding always occurs in the premolar region due to the early loss of the deciduous molars. We commonly extract the first premolar, but again it depends on the condition of the tooth, the position of the tooth, and the ease of extraction of this tooth. If we have a malposed premolar, for example D5, and we cannot extract it, we extract D4 instead. Then we level and align the 5 in the arch. If we have an impacted premolar in a good position and we can easily pull it out, we extract the premolar that erupted in the oral cavity, then pull the impacted premolar out into the arch. But if we have an impacted premolar in an unfavorable position, we refer the patient to the dental surgeon to remove it. There are many factors that indicate whether to extract the 4s or the 5s, but we always favor the extraction of the 4s than the extraction of the 5s, as the 4s lie in the middle of the arch. The relief of the crowding occurs faster. Also, we get a good contact between the 3 and the 5 at the end of treatment that leads to stable results, while in case of extraction of the 5s, the contact between the 4 and the 6 at the end of treatment is poor. It is highly recommended before extraction of the 4s to make sure that the 5s are present and not congenitally missing, which can be checked by radiographic examination. Here we have a case with severe upper and lower anterior crowding, and you can see the relief of the crowding that occurred after the extraction of the 4 fours. The second premolar is extracted if it's severely carious, badly destructed, or it's completely out of the arch with the 4 aligned in a good position, and we can easily access the 5 to extract it. Also extract the 5s in moderate crowding class 2 cases when mesial movement of the molars is required to correct the molar relationship to a class 1 molar relation, as not all of the extraction space is needed to relieve the crowding, but unfortunately it ends up with a poor contact between the 4s and the 6s. The first permanent molar is not usually extracted as it's the key of occlusion, and we use it to classify the orthodontic cases. It's extracted only when it's severely damaged by caries or periapical lesions and it cannot be repaired. But if we extract it, we should extract it after the eruption of the first premolars to maintain the vertical dimension between the 2 arches. If the extraction space is not needed to align the anteriors, we extract the 6s before the eruption of the 7s, so the 7s can erupt in place of the 6s. If the extraction space is needed to align the anteriors, we extract the 6s after the eruption of the 7s, so the 7s does not take the space of the 6s. In anterior open bite cases, the 6s. This case is not a commonly seen case. From the panoramic X-rays, you can see that the upper 6s have moved mesially due to the premature loss of the upper E's. The upper 5s got impacted, and as they tried to erupt, they caused the resorption in the mesial roots of the upper 6s. This case will end up by extracting the 6s to allow for the 5s to erupt in their place. Here, the decision to extract the 6s was based on the resorption that took place. The second permanent molar does not provide space to relieve the anterior crowding. When the 7 is badly decayed, its extraction is either to provide the space for the 8 only if the 8 is sound and not severely inclined, or to provide the space for a crowded or an impacted premolar, as we distalize the 6 after the extraction of the 7 to regain space to level and align the crowded or the impacted premolar. The third molar is not considered in providing space for the correction of an increased overjet or to relieve the crowding. But if it's severely malpositioned and may endanger the roots of the 7, we should place it in the problem list during diagnosis and explain it to the patient or the parents that it must be extracted. We may consider leveling and alignment of the wisdom tooth if it's in a good condition and in an acceptable position in cases where the 6 or the 7 is badly destructed and needs to be extracted. Extraction of the teeth without orthodontic treatment has harmful effects on the whole occlusion. When extraction takes place, the neighboring teeth start drifting and tilting in the extraction space. Some spaces start opening between the teeth, some proximal contacts are lost, the opposing teeth might extrude, and the occlusal forces are not equally distributed on the whole occlusal table, causing traumatic occlusion that leads to injury and disturbance in the periodontium that surrounds the remaining teeth. These extractions will flatten the patient's profile or even turns it into a concave profile. Hence, if extractions is left untreated, it will worsen the patient's profile. Thank you for listening. Stay safe and stay home. God bless you and protect you all.